guest speaker I've invited to visit, so it's wonderful for me to be able to introduce. I've spent some time in Australia, University of Sydney, University of New South Wales, and Macquarie University, but today one of our researchers from University of Sydney, Dr. Tim Shaw, who is in the field of implementation sciences. And it's something that we all need to know quite a bit about. And the topic today will be why do healthcare professionals have so little access to their outcomes data. Dr. Shaw, welcome to
Okay, thank you very much, and thanks for inviting me, Bob. That's great. So it's a pleasure to be here. So I think I maybe bring a slightly different perspective because I'm not a data scientist, and I mean I understand data, and I'm not really an informatist either, but I understand that side of it. So it's I actually began my life as a reproductive biologist many moons ago, but then have been in research and then in implementation science for the last kind of 15 years, really focusing on how evidence translates into practice, which through a backdoor route kind of got me into how we use data around that. So I'm from the University of Sydney. Before I start, I have a disclaimer. Now, I usually use this in kind of talks around the world that I've given, and I've come to realize that teaching your grandmother to suck eggs doesn't resonate at all in America. Does anybody have any idea of what that is? No, okay, so it's an English term. It also works in Canada, France, and a couple of other places where it's kind of diffused. So really what it means, I have no idea where it comes from, but it basically means that there's probably many people in this room that know a lot more about this than I do on some level, so I'm not here to teach you things you don't know. So yeah, that's anyway. You might want to use that in your future yourselves. Don't teach your grandmother how to suck eggs. So to give you a little bit of background, this is the centre I work in. I'm lucky enough to work in this huge multidisciplinary research group called Charles Perkins Centre, which is at the University of Sydney. It's great because we've kind of hung up our disciplines when we go into this building. Everybody comes from multiple faculties and disciplines, but comes into the building and kind of work around discrete projects. So, and health informatics is certainly a component of that work. And the good thing is we're right next door to the big teaching hospitals. We have this really great flow of clinicians and researchers that mostly spend their time in the coffee shop here. And it's been a great environment. So if any of you come over, I'd be very welcome to host you there. So how many people have been to Sydney? Oh, 3. Okay, that's not bad. So just so you get a feel for where we work, Sydney, that's the harbour, we see all the pictures. That's where my building is, but where the hospital I spend most of my time, I don't know if you got out there, Bob, so it's Westmead Hospital. It's, this is actually where Sydney's population resides. It's incredibly culturally diverse and economically diverse as well, so it's a major service centre, and we're actually making a major investment in that as a hospital precinct. All the doctors live here along the beach, so they will have to go to drive out west to service that population. So in terms of where I come from, as I said, I went from reproductive biology actually to digital imaging, then through into professional development and education, particularly using targeted online programs. And then I became frustrated that I couldn't get evidence into practice routinely within organisations and kind of chanced upon implementation science, which is the kind of sister of quality improvement, but from an academic viewpoint. And who's heard of the T's of translational research? Yeah, a few people. So in implementation science or translational research, there's a model by Westmead which refers to these 3 components of translational research, which is basic biomedical. Is that something that's whirring normally? Or? No, it's okay, it's just the heaters. So it's T1 research is basic research, T2 is clinical trials, and then T3 is how you take that trials information into routine practice and broad dissemination. So I kind of live in that T3 space, which is a challenging space to do research when 99% of the NIH funding still goes to T1 and T2. But governments are increasingly realizing that actually we can almost stop discovering things if we just actually applied what we knew into practice already, we'd be getting way ahead. So the pendulum's swinging slightly. So now where I live is I lead implementation research across 2 large translational cancer centres, one at Westmead, I was saying, and one in Sydney itself. So I'm really interested in the role and impact of multidisciplinary teams, which are obviously team-based care in cancer is very dominant. I'm interested in how we use high-impact methods for behaviour change. So I've been doing those for a while, and now that's led me really down into this data-led performance improvement. So it's really how do we start to use the data that we're generating and finding, and how do we actually make behaviour change and implement evidence into practice. So in the oncology space, I work in lung and breast cancer, often in the spaces of pain and supportive care, and then we're just starting out with some programs around cardiology with acute coronary syndrome. So I thought it'd be worth sharing, and look, I'd be really interested in your feedback on this. I'm the inaugural professor of eHealth at the University of Sydney, which is kind of a really interesting role to have, and nobody quite knows what the heck it means, nor me, to be frank, because it's such a massive area. eHealth's everything. My cousins in their 20s think I'm studying ecstasy, because the E, but anyway. So one of the things I've had to do is construct a framework about how do we teach eHealth to all our graduates. Like Sydney's a huge teaching organisation. We teach almost every possible healthcare professional. So what competencies do we need in eHealth for that, so they can use EMR, they can review an app that their patients are going to be using, that kind of stuff. And then how do we have a framework for research, and then how do we actually put it into practice? So we've come up with 3 domains. The one which you're perhaps most interested in, which is the kind of data, which many people traditionally think of EMR, but we're thinking that much more broadly in the concept of all the data flowing from devices and all that type of work. Then probably obviously the fastest growing area, which is largely absent from the acute care sector at the moment, which is kind of health in the hands of consumers. So this is your apps, your mobile phones, your websites, all those kind of things. I think this is where the innovation's happening at the moment. But it's still like the 1800s in pharmacy, when you can buy a pill for baldness and just about anything else. Now you get an app to cure just about anything with no evidence behind them at all. And then the traditional kind of telehealth domain, which I now call how you communicate between a patient and a health professional, and that might relate to how you just do an SMS coaching program for somebody in a weight loss program through to more traditional rural chemotherapy consultations. And I guess where we're starting to look is the kind of sweet spot in here, where you're getting some really nice programs that are starting to integrate mobile technologies and kind of consumer-led stuff, particularly in areas of mental health. So you might have an app that actually triggers a consultation with a health professional when you reach a certain distress level on a handheld device. And then all that data has to get fed down into somewhere where the range of health professionals and the consumer can actually digest that. So that's been a model we found really useful for trying to bring together these different threads of eHealth. And then obviously around that you've got patient safety and quality, privacy and access, research and education. There's a whole pile of different domains I could have put around that. And then really where we're trying to head is to have, we work a lot with our health consumers, so they've got to be informed and active, and they're really kind of driving so much of this, particularly as we move into the wellness space, not looking at acute care so much, but chronic disease management. It's all about really how the consumers handle that, because your acute instances are a tiny part of your life and a tiny part of your health journey, and we still have so much focus on that acute sector. And then obviously we've got to work out how we prepare our professionals, and then we're trying to go towards integrated healthcare. So that's our kind of model. I'm going to talk a little bit about my research in a moment, but I just wanted to give you some of these conceptual frameworks and get your feedback on them. The way I see this, or the way I work from this, is I work across 3 domains of healthcare. So I work across, obviously, professional practice, where care is delivered. I've always had a really long interest in this professional development. I think this is very badly done in healthcare. And then quality improvement, which has obviously been coming along for ages, although the recent report coming out showing that, as we were talking about earlier, that the adverse events are as bad now as they were when To Err Is Human came out. So we've obviously got some way to go with this. And I guess my argument is that these domains in healthcare are fundamentally broken. So there's practically no linkage really between somebody's professional practice and their professional development. Doctors and nurses and other health professionals really self-select the kind of education they do, and we know that people tend to self-select things that don't change behaviour, like going to conferences, going to grand rounds, coming to meetings like this. You don't actually change people's behaviour. It doesn't mean they're bad things. They're good for having thought bubbles and thinking, but they're not good for changing a behaviour. And quality improvement is often done down the corridor. It's actually not really integrated with practice. So my posit now is that really the routine use of performance data, and again, you probably all thought this already, but it's the key thing that will link these three domains together, particularly these two here are ones that need to be linked together. And then, obviously, this has to be done in the envelope of clinical decision support systems that should really ideally integrate these three domains together. I mean, we're still down at the ground floor on clinical decision support around alerts and prompts and things like that. We've got a long way to go, but I think in time they're going to start to bind this together. You should have systems that link your professional development to your practice, to your clinical decision support. So we have kind of prompted learning at key moments in time related to the practices occurring, that kind of thing. And then ultimately, I'm starting to try and develop models where we have integrated systems where we have adaptive education that's responsive to your data and QI, and then quality improvement that's responsive to practice needs and the data of teams and organizations and systems and so on. So I think we can get there, but we've got some way to go. But I do have little flying pigs in that one. I expect that's universal. So we've got some way to go, but I think there's lots of things happening in lots of spaces. I think we need to start to bring it together a little bit more. So on to data. I mean, most of you all work with data. I mean, that's your Department of Informatics. I guess this is your bread and butter. So again, I'm not telling you anything you don't know. I have to teach this to people that don't know anything about it and tell doctors that think it's all part of crap and they don't want to know anything about it. So this might be a little bit basic for you, but I hope it gives you a different angle. So where we're at the moment, I think, in Australia, is that we're at this dangerous tipping point around the missed opportunity and the taken opportunity where most clinicians, they don't see the advantage to actually having electronic medical records. They think it adds time to their practice. They preferred their notes. They really don't like it. I mean, they really don't. It was interesting talking to that meeting. There was a 64-year-old mother of one of the people I was meeting with this morning who's a nurse who's retiring because of it. And that's kind of happening. She doesn't want to go through that process of learning it, what it means to her to carry the carts around and things. So the people I talk to in the system, and this is not necessarily the case here because you've had a fabulous implementation by Bob, but I mean, we need to start to get some real wins in this to show the opportunity around how this is actually making care better than it was before we switched over to the electronic medical record. And I think that's a key concern of most of the teams I know that are trying to implement this. So I think one of the challenges, I think we're at a point of what I call the new health reformation in data. So I think we're kind of in the 1400s when we had monks that had most of the world's knowledge was held in monasteries, written by monks in Latin, that was totally inaccessible to most people. And then we had in Gutenberg, we had the printing press developed, and that totally transformed the way knowledge was used, and it was liberalized, democratized. Everybody could suddenly access that knowledge. The Bible, one of the first things was the Bible was printed in English, which meant that other people would read it, and that suddenly led to the whole part of people being able to read because they read the Bible, and it just transformed everything. I kind of think we're in a similar spot of time at the moment with data. So this is meant to be an epidemiologist. I have lots of friends who are epidemiologists, but I could only find a picture of Will Ferrell, and I don't know what an epidemiologist was kind of characterized as, but anyway. And then your data wonks. And I think they're holding the data at the moment. It's kind of locked in like this, and you have to fill out forms that take, you get a letter back saying you can have this, but it'll take 12 months. That kind of stuff's happening. I do think the mobile technology and these kind of things is actually is the new printing press. I don't think Cerner's using this yet. Cerner's still a little bit like this, an Epic. I think they're still a little bit like that. They still hold it all. They haven't let it go. Whereas if you actually look in my brother-in-law's a senior manager in Salesforce. I don't know if you know that company. Salesforce, they've basically just taken over the whole Australian government. But anyway, that's another argument. But what they do is they really look at how they're one of the leaders of looking at all of us as individuals, what you've just gone and had for lunch, what you purchased on your credit card, all that kind of stuff, and building up a picture of that and making that comprehensive, and then making mobile apps so it's really easy for companies to access that kind of information about their clients. We haven't got to that level yet in healthcare, and I think that's where we need to step to. And so I think we're still stuck kind of down here, and we're just slowly moving across. These people are still important, but at the moment they're the gatekeepers. They're not actually the enablers. Bob and I were talking earlier on that we've got a joint colleague and friend, John Lambert, who's the Chief Clinical Information Officer in our state. And I have regular dinners with John, and he's just tearing his hair out 'cause he's just stuck in the brambles of trying to get the goddamn system in. You know, just trying to make it so the right X-ray and the right pathology results actually turn up at the right time and those kind of things. So they're not looking yet forward, or they want to, but they're struggling with all of them being in the implementation phase of electronic records. So I call it stuck in the brambles. I've got a number of students that are kind of working in this space now. I like this quote from Emily. Emily is actually chair of she's a senior clinician, she's chair of one of our big lung cancer teams. She's a respiratory physician. She got really sick of it and said, I'd like to do a PhD in this, Tim. Can I do one with you? So she is. So what she's kind of looking at is how her, as chair of her multidisciplinary team in cancer, what databases can she access around cohorts of data of the patients she treats, and she can't. It's really hard for her to say, you know, how many people, what's our success rate in terms of getting people within 10 days from first referral to first specialist appointment. She can't kind of access this. There's clinical cancer. There's lots of databases that have been controlled by epidemiologists and big linkage projects, but she can't bring them easily into her clinical practice. And then we've done a number of studies with other doctors. I think this is a key question I'll come back to. And again, I think when you have the system controlled by data people, what I'm finding when I'm speaking to clinicians is they're not asking the right questions that the clinicians want to know. So many of the indicators and stuff that we're dealing with are derived around billing or around accreditation points, or around even measuring things like sepsis, which is really important, but it's kind of peripheral to the cancer team that actually wants to know about their lymphedema rates and those kind of quality indicators. So we've got to be able to start to let the clinicians ask the questions. And then I've done work with a lot of registrars, we call them registrars fellows, and they're dead hungry to have data on their performance, but they can't get it. They maybe will get a workplace-based feedback, they'll get a supervisor's report, that kind of thing. But they can't get feedback about how good were they in their breaking that bad news to that family yesterday about cancer. They just don't get that. Even though we started to get patient-reported outcome measures captured, it's really hard to get that back in a timely way to those clinicians. Maybe that's not the case here, but it's certainly the case in Australia. I've just got, I think, one more slide before I go into some of the research we've been doing, but I've really started to think a lot more about this in a different way in the last 2 weeks. It's one of the great things about travel is you can start to think about stuff. And it's this whole thing, because you don't have time when you're actually working. You come to something like this, have your lunch, then you go, you're back into the mayhem of work. The whole thing with the clinical decision making, I think I hadn't really seen that as the ring that binds all this together. Call me dumb, you probably have, but in terms of, you know, these clinical decision supports is actually the device that's going to bind all this. And it was actually Bob Birnbaum, who's a friend of mine, who leads implementation science at Partners Healthcare in Boston. He told me the story of the latest jet fighters that are coming out, that have been designed. They are so unstable to be maneuverable, because that gives you maximum maneuverability. They're no longer flyable by a human. So they've had to make them so unstable that no human is capable of flying them. And so that's totally made them rethink the way that the pilot is operating within the cockpit and actually flying. So the pilot's basically not flying the plane any longer. It's actually being done by the machine, and then it's a whole different interaction between how the machine works with the pilot. So there's some decisions, many decisions now, it's totally machine made. So when that pilot's flying along, totally unaware of a whole pile of decisions that are being made. There's some decisions still, maybe it's about when to pull the trigger and those kind of things that are still being made by the pilot. And then there's some that are kind of a mixed support mode in here. And I think we're kind of, in healthcare, I think we're still way down here. Maybe a little bit supported in here. But it's like you were saying, Bob, earlier on about some of the sepsis prompts and things like that. You know, how long is it until the system actually starts to say this patient's got sepsis and actually makes the order? I mean, seriously. I mean, that's not far away. And so then how does that all fit together? And then how long till the system starts to recognise that you're not doing that order in time, and it fires off a case scenario to you that evening that actually challenges you on that and gives you your data on your feedback. So I mean, I think that's the kind of, to me, that's the future of the kind of clinical decision support. So I think, yeah, we're still stuck firmly in the kind of Second World War cockpit here, but I don't think it's long till we go over here. I hate using the airline industry as an analogy because it's so overused in safety and quality, but I think in that instance, it just really struck me with the aeroplane. Okay, so I've got one more slide. This is one, I went to a conference in Washington about 2 years ago, but this was the only slide they used for the whole conference. One of the best conferences I've ever been to. It was about knowledge translation and knowledge use, and it's really stuck with me it's really informed a lot of what I've done. That we've got we've got two domains of knowledge. You've got tacit knowledge and explicit knowledge. Explicit being the kind of things that it's pre-prepared, it's edited, it's books, it's databases, it's those kind of things. And healthcare kind of lives down here. We look at our published journals, that's everything we do. But in fact, most of the learning in healthcare works in the tacit space. It's conversational, it's spontaneous, it's on the fly, it's those kind of meetings that you have, it's how teams get together and they work. They might take a bit of explicit knowledge, but then they make it part of a tacit learning experience. And I think mistakes we make so often in how we do things in healthcare is we actually deliver everything down in this space. But we don't actually think, and I think data is a classic example of this. So we're not really putting it down. We're not taking that data and making it available in the normal learning space that clinicians work in. So certainly in my space of linking data to professional development, I think in the tacit knowledge space, or in the explicit knowledge space, that's where you have grand rounds, workshops, nursing in-service things. I mean, there's evidence that these just don't work. And then I think the EMR at the moment sits down here. To make it work, we need to lift it up here into the kind of taking the data into peer-to-team interactions. We need to have micro-learning experiences that relate to people's data, that use case scenarios and so on. I think that's where we're actually going to change things. Okay, so in the next kind of 15 minutes, and maybe we'll have some time for discussion if you want to hear more. This is the kind of evolution, I guess, of why I'm standing here now. I began in the kind of 90s playing with the first kind of online learning programs that came out and built a number of our own online systems. And then, as I mentioned before, I became frustrated with just doing online learning and started to look at much more complex interventions to change practice, where education is just a component. At that time, I also realized you got a lot more funding if you called yourself an implementation scientist rather than an educationalist. It was great. It's been my single big point of advice to educationalists is don't call yourself one, and never put education on your grant application. And then I started to move much more into how we use audit and feedback around performance, embedding it in that process. And then that's led me to go, well, how the heck do we get this data? And we can't be doing massive longitudinal epidemiologically driven things that take 4 years for the data to pop out and the clinicians move well past it. We need to find ways to make this much more rapid, which has led me to looking at team-based programs of work. And then the other key thing is how do we make this part of normal business? If you've got an ARHQ grant or an NIH grant of $4 million, anybody can do a QI program or an initiative. The challenge is to make it part of normal business, which is, I guess, Bob's job. You know, to say how do you do this so it's normal. So the first project I did was I was living in Boston for a year, and I met this surgeon who had this new methodology called Q-Stream. He's a urologist. I thought Q-Stream was a bit corny for the name, but anyway, urologists are like that. So we had, it's a really simple system. I'll show you in a moment. It just fires scenarios at people. He's a very smart man, the guy that invented. He's become quite a good friend, actually. And he found two effects, the spacing and the testing effect is, and we've known this for years, but if you test somebody on something, they'll learn it better than if you just give them information passively. We've known that for a long time. And then the spacing effect is if you repeat that information over a period of time, the impact on behavior and outcomes is phenomenally changed. It's a massive rank up in your memory. And I always say that I've got 2 kids, and the reason they repeat on TV, the reason people sell stuff and they repeat the adverts on television is not in case you missed it. They very carefully calculate the spacing of these adverts to reinforce that learning. So that's exactly why adverts repeat on TV. So it has this massive kind of exponential growth on what you remember. So anyway, he's turned it into this neat tool. I tested on all the 400 interns at Brigham. This was me pretending to be a theatre nurse. And we had them doing a central line insertion, and we actually managed to show of the 4, we did an RCT randomized trial that we had a significant improvement amongst the interns that had done the course as opposed to the ones that hadn't. So that was great. That's led us on to then using this methodology in a number of studies. The first one was one I did, sorry, this is an example. It's really simple. Here's a scenario you get. you get a number of choices, you get immediate feedback on your performance against your colleagues, and then a take-home message, and then some feedback. So I use this a lot around, it's really, if you want to change 12 behaviours around pain in an organisation, I get together with a team, we pick those 12 behaviours, and then you put them into cases, and we found them to be very effective. So I went on after that study to do a study with 600 nurses at 2 of Brigham's hospitals and 1 of Mass General units, where we started to, this is my first go at linking data to a micro-learning experience, where we started to look at trends in the organisation, look at the adverse event data and fire out cases to the units based on those. So if something happened, we'd send it out within that week, we'd send scenarios out. And then we also had a series of cases around national data trends. And it was really well received, actually. It was, I like this quote from one of the nurse managers, most talked about educational activity in the memory of the leaders. And we actually set it up as a competition. And it's become a tradition now when I run these competitions that the winner gets a boomerang. It's a bit corny, but everybody loves it. And we had the units competing, so about who gets the cases right first, and this was the nurse manager here. But again, it's taking that learning, taking the boring kind of QI data, turning it into a real scenario. We even actually took photos of the nurses and had them in the cases, so that they'd be actors in it, and then it's lifting that up into the tacit learning space from the explicit data space. So then that's now gone on. We've just done a big mixed method, a quasi-randomized study on pain scores. Again, this is using data. So Sacred Heart Hospice was one of our lead palliative care facilities that found out they had shockingly bad self-reported pain scores amongst patients. So we used a Q-stream program targeting that. We actually targeted pain assessment and improved it from 22% to 95%, and nearly had a 2-point change in self-reported pain scores. 2 points is considered to be pharmaceutically relevant. So we're doing pretty well. It's just an online program using audit and feedback data. We're now going into larger studies in cancer management, and we've got a big RCT going out using using Q-stream and other methods to stop pain. That's led us to do last year we ran a competition, or end of 2014, where we had competitions between Mass General fellows, Sydney fellows and Danish fellows. I don't know, but there was this Danish prince went to Australia during the, I think it was during the Olympics, and married somebody, and so she became a princess in Denmark. So suddenly we have all this relationship with Denmark now, so everything's Danish, which is kind of bizarre. But anyway, it's good fun. They're nice people. So we had this 3-way competition, again using that Q-stream platform, again responding to adverse events within the organisations, and it went really well. Australia won, but it wasn't rigged. Okay, so that leads me, I guess, to my major body of work. So we're looking in Sydney in Westmead Hospital. We're looking at how we can really change the way care is delivered around cancer care and combining research and practice. So the way I'm kind of conceiving this is, if you're a patient in hospital, if you're a cancer patient in hospital, at the moment, there's a certain amount of data. I should have made that much bigger, actually, and these much smaller. But at the moment, you've got things like pathology, you've got your imaging, maybe your referral things, that kind of information. Maybe history is known about you. There's then kind of emerging data that's starting to come out, and I put genomics in that. I mean, genomics is just something that's going kaboom, and we don't really know. It's well exceeding our understanding of how we use it in treatment at the moment. It's a huge wad of data that's emerging. And then you've got patient-reported outcome measures, another key data point that's been collected, but we really don't know how to integrate it into current normal use. And then we've got this whole new data, which is everybody's got sitting on their desktop now, and you probably, how many people have got some kind of a fitness device? 1, 2, yeah, 3 or 4. It's funny, because I usually ask this to young audiences that don't have them. If you ask slightly older audiences, they all do, so they're trying to stay fit and keep moving and things like that. It's quite funny, but...
Only the thin people.
Yeah, that's right. You're dead right. It's thin people. I should have done that. I won't take that there now. But Yeah, so all this is, and your purchasing power. So when I'm teaching this, I'm always talking to people. I get them to do a study on what's being collected about them that might be relevant to their health. So there's a massive data out here, and we're only still stuck here. But I think as you move forward as health professionals, you're going to have to start to think about how this data all fits together. Then what really interests me is if you take all of these. So if you're the cancer multidisciplinary team here, and you take your patient cohort, that suddenly ramps up the data that's available. And then how do you start to use that data in clinical decision support, professional development, and quality improvement? So EMR at the moment is down here, really. It's just about managing so that current data links to this patient. That's fundamentally what it's about, so the clinicians can manage the session of care for that patient. They're nowhere near, at least not in Australia, having this kind of cohort data to allow us to ask these kind of questions. Does that resonate? You agree with that? Okay, so we've got a 5-year program of work we've been looking at. The first one was we did an ethnographic study of, it's a big we actually, I had research assistants that sat through, I'll show you the stats in a moment, about 40 teams to look at how they intersected with data. We're just at the beginning of working out how we work with clinicians to ask questions, and then we're going into looking at doing a systematic approach to this so that we can actually start to demonstrate that the work we do with data actually impacts on outcomes, otherwise what's the point? So we have to start to look at that rigorously. So the first qualitative phase we looked at 43 teams, had interviews with a whole pile of different people in this, and what we actually found was that multidisciplinary teams, they certainly use kind of clinical trials data a lot in their decision making. Some of them generate it, so some teams are actively participating in clinical trials. A number of teams engage in basic research. Practically no team was engaged in T3 kind of implementation research or quality improvement, and they were hardly using data at all. So they were hardly using cohort data in the decision. They didn't sit down and say, how have we performed in the last year on this? It wasn't part of their. A couple of teams did, but I'd say 90% of the teams didn't do that. When we asked them what they wanted that would change that, it was definitely integrated data, audit, and feedback was their number one requirement. They needed leadership and support to do this. They wanted embedded expertise, so they wanted access to quality improvement people. We have to find ways in healthcare, and I think this is really important for people in data and informatics to understand that you just can't give people data. You've got to find the way to make this part of normal business. So you've probably got to have occasional extraordinary meetings within the system. They don't have time to deal with the data in their normal business. So we've got to find, there's no point just working on data if you don't work on how it gets used in the system. Otherwise, you're just wasting your time, entirely wasting your time, because clinicians won't use it. They'll use it if there's a grant running, but then it'll stop. And then we actually found that some of the most progressive teams were actually using research fellows, and med students were really useful at facilitators the use of data. So this led us to it was actually one of my research assistants, a bit creative. So this is, we worked out the kind of factors that were important for teams to engage in the different types of research, and integrated data was one of the key stems that supports all of that. Okay, this is my last slide. So our current scenario that we're working through is that we're starting off with a multidisciplinary team. So in my case, that's the breast cancer team. I think it's really important that the first thing we do is ask those teams to set their own clinical questions. I think the problem is we often go to a team and say, we're going to work on sepsis with you, or this is what we're going to do to you, rather than what questions you want to ask. And it's really important we've got consumers in here. So we've got breast cancer survivors as part of this question setting team. Obviously it's got to be informed by evidence and indicators and stuff like that. But what we tend to do is we go away and do this bit, look at evidence, look at factors and things like that, then present that to the team and say, this is what we found. Do you agree with it? What's relevant to you? Would you like to add things to what we're looking at? In fact, one of the things we're looking at is survivorship issues, and the clinicians wanted to look at some aspects of side effects, and the consumers actually know the thing that we really struggle with is maintaining our endocrine therapy. These are women that are on tamoxifen for maybe 5 to 10 years' time. And whilst the side effects aren't what the doctor would say are really significant, they're a pain in the ass to the women. They hate it, and so they drop off treatment. And that's poor. And the consumers are the ones that came up with that question, and the clinicians went, really? Okay, and that was really important to them then. So that's one of our studies we've got coming out of that. But then what we're starting to do is say, okay, what EMR databases can we explore to answer these questions? I think the other key thing in the visualization of data is if you've got your question, then suddenly you can build your answers and your visualization around the question you're asking. So I was with cardiologists the other day, and they were looking at data, and they had a data person that was just throwing data on the wall. It was like waves of data being thrown on the wall. The clinicians were kind of glazing over. And then they start to dive in and they pick out ridiculous things. They'll look at one thing and go, look at that data point. And they'll spend an hour talking about a data point that's totally irrelevant. Actually, Todd nodding, I'm sure you've had this kind of experience before. I use the analogy as a bit like kids at a dressing up box. They're kind of leaping into the dressing up box and they'll grab a pirate's hat and they'll put a nurse's outfit on and something else and they'll walk out, like this. And they don't go in and say, I want to be a pirate. And therefore they go and find the hat, they find the boots that fit best and so on, and then they come out looking like the right person at the beginning. So if you come out looking crazy, then it takes you ages. I mean, kids like that, but it's not very helpful. So that, I think, is really important. And then what we're starting to say, now this is, I have the enormous luxury of being a researcher. So at this point, I can do like the cooking show where they say, we've had this in the oven for 3 hours and we can bring it out now and say, now we can go on to putting the icing on the cake or whatever. Because, there's a massive step between what I'm about to say now, that's what I'm saying up here, and the reality of this. But some of the things Bob's been telling me in the last half hour, I think CERN is creating tools that can do some of this. So we're starting to look at, the first thing is how can we take cohort data addressing these clinical questions and put it into routine practice within the team. Still, they're fundamentally making it about helping that team have peer-to-peer interaction, have tacit learning experiences around that data. And there's a heap of qualitative work to do up there as well as quantitative. And obviously to support that, we've got the data dashboards and visualizations. But I know you've been sending prompts out, like email to clinicians. I mean, obviously that's one way of getting out, but fundamentally it's probably not going to have a huge impact. I mean, clinicians just don't open emails. So we've got to find better ways of getting the dashboards into practice. And we're working with our faculties of IT and engineering to do, can we have some interactive desktops? Can we throw something on the wall that every time they, even just with a data projector, every time they walk into the multidisciplinary team meeting, they've got something there. Ideally, it'd be an interactive though, so the doctors can stand around and play with the data themselves. And then, this has been my kind of passion is then, can we automate the process of education so that based on the data or the team performance, you get different types of education being sent out to different people. At the moment, we do carpet bombing with education on the whole. Everybody gets the same thing. So you do an in-service, every nurse comes in and gets the same in-service education. And Bob and 3 other clinicians might have quite different panels of patients. They might have quite different outcomes. There might be different stages of their career. So we should be using the data to inform that. Again, this is still, I'd say, 5 years away. But you've got the tools with QStream. It's very easy to suddenly hook that in and start to automate the send-out process. And then obviously this generation of continuous quality improvement. I should have had a vertical kind of arrow through this because I think if quality improvement's not integrated up into this, then it's always sitting outside, and you kind of have people that turn up and do quality improvement, and then they don't, then they go away and it all stops. But then something that, and then obviously this whole decision support systems, I don't quite know yet how this is going to support that, but it needs to. This is the control panel. This is the cockpit piece that we need to work out. This is the engine that says what's it going to do and what does it send out. And then obviously that's a cyclical loop. But then for me, again, I spent years trying to get doctors to change behaviour. You've got to start to link this into things like maintenance and certification. You've got to make these things relevant. So it all closes some loops down. And then we're only just at the beginning of this, and Bob, again, you were just talking before we came in about this cross-site comparison and how do you do that without it becoming some kind of, a competition between sites to look better so they can get more patients in. So my idea is that these teams will share this information and we've got to keep it out of the public, not out of the public, keep it out of that just shooting match that happens between organisations. So I think that's it. I'll just go back to that. So that was a quick fly through of the kind of stuff we're looking at. But I'm certainly open to questions. And you know, tell me if people are doing this already, because I'm actually not finding people that are kind of closing this gap at the moment.
That's a good spot, I guess, to turn it over to some questions. First, I'll take time to shop for the background. We'll get the time to start asking some questions. So start with Ellen.
So I actually have a couple of general questions. Number one, for a very nice presentation, lots of great work, and I just got back from Boston, and you may know Griffin Weber.
I know the name. I don't know him.
So he does lots of stuff. He's a boy wonder over there.
Where is he? He's in MGH, or?
He is the Partners, I think.
Right. Yeah.
I always get mixed up with MGH, Brigham, and Partners.
Well, they're all owned by partners. Yeah.
Right. So anyway, so he does. He every once in a while comes out with this chart that summarizes a bunch of data that makes you realize that what you're doing is all wrong.
Yeah.
I hate that when he does that. So his latest chart is you looked at if you will, the influence of the health, what he calls health system dynamics versus the biology. Okay. And so right in the middle you have various questions. You have EMR databases. You do some sort of analysis on these data, and you get some sort of guidance that might be presented or to change behavior. Is that basically
pretty well. Yeah.
So one of the things he found is that if you look at, and this is just one example, white counts. Okay, so people get blood counts. If you get a blood count at 3 a.m., you are much more likely to die. And that's a much bigger effect than the actual result. So in other words, a normal white count at 3 a.m. is much worse predictor, a more negative predictor, as it implies much greater mortality, than a high white count or a low white count at 2 p.m. Now, the clinicians know probably why, because you don't get routine blood counts at 3 a.m. Somebody's probably sick, and you're poking them at 3 a.m. And he actually has a chart where he has maybe 100 different blood tests, and some of them, or tests, not necessarily blood tests, some of them, the effect on mortality is driven by biology. Some of them, the effect on mortality is driven by health system dynamics, and some are in the middle. Given that kind of stuff, and Todd and I wrote a paper with, is Frank here? Sorry. Frank wrote a paper, there you go, showing that with prednisone and weight gain, depending on what assumptions you make, you can show weight gain, weight loss, and all that. So if you can't discover that prednisone causes weight gain, which I think most
everybody would agree,
then where are we with telling people what to do based on data?
Yeah, no, I agree. And I think the data distrust piece amongst clinicians is massive. So,
but it's, I guess I would argue that it's not entirely unfounded distrust.
No. I agree entirely. So I guess, but I don't think that's a reason to not do it. So I guess that's. Yeah, I think that's where I leave it to smart data scientists to do that. So like in our group, we just put in 6 new data scientists, and one of their primary roles is to do that. And I know Todd's trying to do this as well. It's like, how do you actually look at that? And I don't think, to be honest, we can do it at the moment. I think we maybe do it for certain data points. I think there's things like pain's an easy one, right? It's pretty simple. It's a single point. It's a self-reported pain score. It's fairly unambiguous how you pain. Well, that's not true either. It's moving up and down. But I mean, we use it as an outcome measure, and we could actually use that as we use it to show a difference in the impact, but then it could also be fed back to the clinicians. So that's a little bit easier.
So pain's a great example. So Sanjay Gupta, who was a classmate of mine, believe it or not, now is saying, it's the doctor's fault, the whole heroin epidemic, it's all the doctor's fault because we've been taught that to manage the pain, wake the patient up, ask them if they're in pain, and then give them narcotics. And so they get out of the hospital, they're addicted to narcotics, and then it's a very short step to heroin. So here's this massive campaign, right, in the 1990s,
early 2000, something like that.
We need to change behavior, and now we're saying, whoops.
Yeah, I agree when you look at it globally. When you look at it locally at a unit like we were looking at, what we actually found out was that they weren't doing adequate pain assessments. So I think you have those global influences, but if you look at a unit as it's moving through time slowly, when we really observed what was happening in that palliative care unit we were working in, they're pretty good at managing the opioid bit. And I expected it to be down that end, to be honest. I thought when we started talking to the teams that the problem was going to be down the opioid management end, but it actually came down to the fact that nurses weren't doing adequate pain assessment. So, and if you don't know what the pain is to start with, then you can't treat it. So we targeted our entire program at pain assessment, and then we found this downstream effect on self-reported routine, not pain assessment in the middle of the night because somebody was in pain, routine daily pain assessment. So I think you can do things like that. Yeah, it's hard. I mean, there's other measures we're looking at about things like.
And I don't mean to. And by the way, to be fair to you, you're not asking the question of what should we study, what measures should we optimize. I would argue, by the way, the data scientists aren't going to answer these questions.
No.
In fact, they are very poor at answering these questions. So, for example, data scientists discover things like people with arterial venous fistula tend to have renal failure.
Yeah. There's a gorgeous paper. I can't remember. Somebody quoted the other day of ridiculous associations in healthcare. Yeah, it was really nice. That none of them were kind of relevant at all. So I agree with that. That's why I kind of said the magic box thing that has to occur here.
So criticizing your work.
Again, I guess
it just seems like such a big problem.
Yeah. But I guess that's why the other thing is that I think when you're going after big ticket items, it's harder. So with the clinical teams we're looking at, say with the breast one, we're looking at lymphedema, which is something that's fairly manageable and important to that team. So we can work through the points of lymphedema. I mean, I know there's lots of complexity around that as well, but there's a certain number of points we can get bioimpedance and those types of things. That's routinely collected. So we're trying to start it simple rather than going for things where we overreach and try and do some complex data where we actually get down to the end and go, geez, we stuffed that up, is the kind of approach. But yeah, I'm with you. I'm glad I've got a 5-year grant.
I guess one way to go about this is, I think this is exactly what he says. Look, we don't know how to use data to answer.
Sorry, I didn't hear that.
We don't know how to use data to answer everything.
Yeah, absolutely. Yeah.
But maybe there are a few things that we can, and then the trick is picking those things, and then all of your work.
Yeah, and this is one of the problems, is I know that every person I speak to that's in this position of prioritizing they're just getting this list that is ridiculously long of requests for projects that's growing exponentially, and they tend to work through either patronage or political pressure or just chronologically or whatever, but as you said, there's not some kind of a filter thing to say these are the ones we should be working on. Well, which is why I guess I'm going to the teams and letting them set the agenda. But
Another question, I have a couple, I'll finish up on that. We've installed a new rule when Dr. Murphy is the introducer. If you get a free lunch, you must ask a question.
That's a long question.
One or two will do. Does this relate to any of your work? Probably not.
Okay, we're going to call that the Murphy rule going forward, right?
Are you sure you want 25 questions?
Please be prepared with them as you come in.
You maybe call that.
Well, I'll follow up with one, Tim, because I think the aspect of data scientists and things, I mean, with a lot of our work is directed on that, almost more the technical side. But I'm quite fascinated too with the human side on this. The point about professional development being an individual versus a team-enabled environment, I don't know if you could expand a little bit on that, because again, as a physician, having to do the maintenance of certification, and I mean, it is extremely individual, get your CME credits, check the box, and you're done. Yeah. Versus the tacit knowledge you gain from your mentorships and your relationships, and in the care of patients, the patients often are our best teachers, some emotion. But the nature of the emotional impact that a team helps create with you as a shared goal and outcome, as opposed to the individual. And
yeah, so I mean, I guess that's why I had this In fact, I didn't have this one at the top of the list before I went to Boston. I presented this to some colleagues at Boston. So I mean, that's what I'm saying here. I think this to me is the most active learning component of this, probably, is that team-based peer discussion type activity. But how you quantify that and how you link it with this is hard. So these tend to be more individual because that's how learning is structured, but I think it's this learning that's occurring up here that we support, particularly for senior clinicians. It's, you know, fellows and trainees and things like that tend to work down in here. They get a lot of individual type work, and they sit on the periphery often of this as a learning experience, but the only way you'll get a senior clinician to learn is this kind of learning on the run, that experiential learning up the top. That's how we call that. I mean, that's how I would cast that. So that's why I've made this the kind of gold standard. I still think the gold standard learning experience is a set of professionals coming together to discuss clinical experiences with adequate data. It would be my kind of gold standard of professional development in that situation, ideally in a guided, well-structured program.
I'm familiar with numbers during internal medicine, I think, that's correct, but we didn't have we didn't have emergency medicine, but in internal medicine for the last 5 years or so, they've actually had a component of your board recertification that is a team-based quality improvement activity.
Yeah.
Which you must And I think it's been an abysmal failure.
Yeah.
And they now, I think, are considering or they have abandoned it. My wife was in that program, but
it's
seemed
such a shame.
well-intentioned.
Yeah.
But extremely difficult to.
But where I've heard that work, right, was again talking to some colleagues in Boston, where they let the teams they took this and they built it into this process. So they actually said, what do the teams want to work on? Instead of each individual physician trying to go out and pick a project and do it and half-baked do it, they actually got teams of clinicians together to self-select and take the program through and then say they've done their maintenance of certification at the end, which is a much better way of doing it. Because then you take that team process down through. QI done in that individual way is doomed to failure. So,
just FYI, there's a rebellion in internal medicine with respect to the maintenance of certification.
I know, yeah.
And I don't know if that's going on in other specialties as well, that people are really.
But it's interesting. So I did a program with head and neck surgeons, so a tricky group of people to work with on the whole.
Bad people in general.
Yeah, some of my best friends, I know, but it's okay. No, I mean, they're great, but we took QStream and we took as guidelines went out for head and neck surgery, so I was working with our cancer council that produces guidelines, and nobody reads. They kind of go out. Oh, they do read them, but kind of half-heartedly. And so then we took out what are the real changes in this guideline from the last set of guidelines, turned them into 10 cases and started to fire them out to people as those guidelines came out. So instead of them having to go and try and reference the guideline and see what's changed and what's meaning for their practice, and they loved it. So we had like a 90% completion then of that individual thing. And then we've also put discussion forums in around this. So I ran another one for clinicians where we had an ethics program for senior clinicians. And we pitched it we actually pitched it around technology, because a lot of senior clinicians don't know whether you can take a photo rurally and email it to your mate or email it back to hospital. And then we had a discussion forum. Instead of feedback, we had a discussion forum. We had this amazing interaction. We had about a 40% participation in a forum, which is phenomenal. Normally it's about 10%. So that gets back to some of your teen learning. So I think you can take some of this stuff and make it team-based and experiential, but you have to make it built around cases, because that's how clinicians learn, if that makes sense. So to me, I would scrap the maintenance of competency, start to build it into these things which are much more adaptive and responsive to your needs. So if you started to get the odd case at you as guidelines were updated, and I think the College of Anaesthetists here has started to do that with QStream. I think they're one group that's actually been looking at this to start to say, if you do these kind of monthly cases, then you don't have to do this 5-yearly program. It starts to take some of that out.
Doing that with tests. One probably not the right word, but one challenge, I guess, is certification is fundamentally an individual sport.
Yeah.
And so, how do we build in the team? So our work is team-based. I'll certainly buy that. But our certification is individual.
Yeah.
So how do we?
I think it's a huge problem. And look, we've just had a scandal in Australia where we had a med-onc, actually in the hospital I was working at, it was St Vincent's, who decided he wanted to half dose his ovarian cancer patients and head and neck with carboplatin. He half dosed them because he thought the side effects were too severe, the symptoms. And he was doing it for 2 years. And everybody knew him, and I was actually in the hospital working with those teams, and he was always the guy that never showed up. You know, he was a senior clinician, a senior leader, and he never showed up. And so he wasn't doing anything that was kind of criminally negligent, probably. And he's got his lawyers now, I'm sure, stacked up, showing the 10 papers that show that there's ambiguity about the guidelines around that particular dosage or whatever. But the team should have actually taken that on board. And so now a lot of the teams are reflecting on how does the team actually have a process to enable that, so you don't get these outlier clinicians that it's very easy to pick the real outliers, they get pulled, but it's the people that are a little bit out, and I think the teams have to pull that. And then you've got to have the data, though. So now, actually, my wife's responsible for the analysis of this program, and or what's been happening. So they're interviewing patients and the whole part, and they're trying to go back through the data, and it's really hard. So that data should have been available to the team in some way. Right. Oh, I've got a question. There we go.
Yeah.
Oh, the one I start here and then go to the back. Great. So two. That's good. They deserve their lunch.
So I'm curious about, so these activities would be sort of new activities added to the practice, right? Would be like how these kind of efforts would get paid, by insurance or?
Yeah. Well, I mean, Australia is a slightly different system, so we don't have quite the same dominance in the insurance model. But what do you mean in the activities? These.
For example,
So the team meets. Okay, so they meet, but they meet every week, right? So we have this bizarre thing in Australia where our senior clinical leaders in oncology meet every week, and all they do is discuss 10 patients. Right? It's good because
tumor board.
yeah, it is. But that's
Same as our thing.
yeah, but it's a massively lost opportunity to do more. So that's what we're arguing. So the tumour boards that I found to be most effective are ones that probably have a 6-weekly, they call it an extraordinary meeting, where they actually then look at the data and they do it in a different way. And so we need to support those. So that's why we had that flower diagrams, the kind of thing you need to do. There's certain things you need to support those teams, but it has to be part of normal business. If we had to create another workshop, forget it. No way. There's no way clinicians would turn up, even unless you paid them an awful lot. They're not going to show up to another meeting. So you have to try and make it. You have to change normal business to accommodate data. I'm sure that's what you've looked at, Bill.
The two types of covers I think about, one of the types, like a tumor board, you look at individual cases in great depth, and that's some benefit. Or the other one is something where someone's presenting research, in the true research sense. So I think there's a middle zone there.
Yeah, exactly.
The data that's being produced within the care of the patients, they can analyze that and present it back for more immediate feedback.
Exactly. Yeah, and we do have those two domains, but there's not a lot happening in the middle. So the teams that get that right, so our melanoma team in Australia, for some reason they've got that right. It's actually down to the leader. We've got a really strong clinical lead, well respected, that's kind of driven that, and everybody shows up for the extraordinary meeting. But you can't make it extra. There was a question at the back.
Yeah, you put a lot of work into developing your multidisciplinary teams and understanding the dynamics around it. And you were saying that in Australia you're still in that phase of a heavy implementation. So are you incorporating those teams into that implementation process to sort of configure these systems to give you the information that you need?
Sorry, am I getting the teams to be part of?
It's just you've done a lot of work in the team structures and
Yeah.
the important dynamics of the teams.
Yes,
Are they getting involved in
even in the rollouts of the EMRs and things like that.
Yeah.
Look, I actually think no way and nowhere near enough. I think what's happened in Australia with the EMR, we've almost been blindsided by it. That's what I've felt in the last few years, that clinicians have been going along, there's been this thing kind of happening out there that data's, we're going to move from paper and we're going to digital, and there's obviously been attempts to engage clinicians in that process. But still, we fundamentally taken a billing system through Cerner and EMR and Epic and put it in to do what we want to do. And I think now the clinicians are suddenly waking up and going, geez, it's here, and it's actually not giving us a lot of stuff. I know you're working really hard to make that happen, but I think it's fair to say most clinicians in Australia think EMR sucks in terms of the fact it sucks data in and it doesn't readily give it back. at the moment, and so our team. So I'm trying to take that back now with those teams. So we start again with the teams. So like I'm lucky. So we're just putting in the Cerner oncology module in at the moment, and the breast team's really excited about that. And we've got them right at the ground floor, saying, okay, the data's going to start going. We just started using Mosaic, so we've got 2 different systems, and they're quite excited about it now. So they feel that they're right there from the beginning of this happening. So I have no trouble calling up the surgeon saying, can we meet? She'd say, sure, tomorrow at 12. Normally she'd go, 4 weeks time maybe. So I think you're right. You've got to engage those teams. The problem with multidisciplinary teams in cancer is there's very little evidence to have impact on outcomes, but that's another whole talk.
I think that idea is a brilliant one, especially with Dr. Shaw's work. I can tell you, in the United States, I don't know that that's well done, and I can share the experience of the neurosurgeons who did their rounds. They have a team-based round, nurses, pharmacists, everyone there. But when you go into their room, you have 7 different monitors. They each sit with their back to each other, and they're talking about cases, but what they're really doing is they're each looking at their individual screens, kind of shouting out what they need.
Yeah.
We never thought about how do you design some type of the EMR to facilitate team-based information sharing. So
exactly.
that's a great question.
Yeah, that is good. And that's why we're looking at the interactive dashboard tops and things like that to say, can we actually do some really groovy things? So look at my colleagues in that working around that. So
they have a sister module along with their Millennium product that is all around staff shifting, but it can help and assist with all the certification and competencies.
I've got to look at that one. I've heard that. So, yeah, the funny thing, just as a final anecdote, is if you ask a patient what they think about multidisciplinary teams, we had this young guy we asked, and he had this lovely view. He thought that, well, first he thought it was disciplinary, so he thought somebody was in trouble, which is really funny. Then he had he gave a talk, actually, this great picture of just that, where there were rows of 30 or 40 clinicians over screens looking at his treatment and how they do it. Not that it's this kind of fairly random event where people run in with coffee cups and donuts and kind of sit down for half an hour and talk. So the teams are so different. They're so different. Anyway.
Guys, this is a fascinating talk. Dr. Tim Shaw, thank you so much for being with us today. Thank you all for the seminar.